So we'll just a brief history about 1900. Albert Abraham Michelson invented interferometer. It's a basic principle that we all now know, that it's based on the principle of interferometry. It's then the first in vivo imaging was in 1990s. You'll be surprised to know that the OCT was first used in cardiology, not in ophthalmology. But as we are optically accessible, most of the new gadgets in science helps us by coming into our domain. First commercial time domain OCT was introduced in 1996. The young ophthalmologists will not be aware it was such a big leap for us. I cannot tell you the feeling that we got once we got this machine and started diagnosing, which we are not able to do. We started treating the patients when possibly we thought doesn't need treatment. And of course, the big change again came with the spectral domain OCT, when things became much easier to interpret, much faster, much comfortable for the patient. I'll just give you a basic guideline how to interpret your OCT findings. You should visualize a retina like a building coming up. You have beams, you have pillars. So your all horizontal structures are like beams, and the columns are your Muller cells. As we all know that they guide the pathologies in the retina to appear differently. A flame-shaped hemorrhage in the neural retina, whereas a deeper retina will give a dot and blot hemorrhages. So OCT at the same time you must interpret when you are interpreting OCT, because the retinal structure is like a building coming up. This is just to give you a brief history what imaging that we have and what is the resolution. The confocal is of course the most resolving gadget we have, 1 micron. The ultra high resolution OCT again is coming, which is possibly right now in more of investigative domain than in clinical practice. The more we had around 10 microns of OCT coming. Octa of course has totally changed the this whole spectrum. Ultrasound we are all aware, and high resolution OCT 300 micron and MRI 1 millimeter. Here I will just like to give a basic idea of the young ophthalmologists that you should see OCT like an ultrasound. Where in ultrasound you use sound waves, here we use light waves. So the problem with the light waves will be that it might have obstruction, may not get that good vision in a media which is not that good. But at the same time, because of the low wavelength, the light always give you a better resolution than ultrasound. So it's like an ultrasound with the light. So that way, the reflectivity, the absorption, the shadowing, everything you can superimpose, and you will get a good idea how the OCT will work and look like. So this is just giving a normal that we are all aware. You have pointer? Okay, so as we already talked about the low coherence interferometry, that there are two mirrors, that one reflects and other catches, and in between this is basically an area of physics that we cannot go into deep into that. And what we are basically concerned with the type of image that you get. And remember that these images are basically made by the computers, their software, so it can vary from patient machine to machine. See, this is a spectral domain OCT, and this is a time domain. Here literally the pilot has to look out to land. So we need a lot of time. The patient also have to be on longer time on the machine to interpret a lot of data and that to see in that time. Well, the spectral domain, because of its simultaneous high, resolving capacity, it gives you a much faster, much clearer picture, and normally doesn't miss out. Whereas in time domain, sometimes we used to miss out some of the macro lesions. The spectral domain doesn't give us that scope to miss out because it takes the whole picture in one go. So this is a big change that we all came to have. This is a detailed of all the machine that we have. This was the first one. I think we are all very thankful to this machine to give us a real insight in retinal disease. Of course, then the improvement is taking place, and day by day we are getting better machines. So these are all machines that we are having. We are all aware of that. This is a normal OCT that you will have. So just one thing that I like to highlight here, you are seeing a black and white picture. Actually, this is the ideal OCT that we should give to the patient, but normally we give pseudo colors. Pseudo colors sometimes miss out some of the lesions which are not that clear. And one thing we like to just have, these are the think that you will come across is alright, but see, this is a line. This is nowadays we look for this line in a poor vision. We are not to find out why. So always look for this ISOS junction, or sometimes say it is a ellipsoid area that comes. This, if you see this area, it is leaving for a while. That is leaving the RP for a while at the fovea. It's because the cones are very thick here, so there is a vacuum in between. It's not that the cones are not attached to the RP at this stage, but there is a gap because the light wave will only catch when there is obstruction. So this is a vacuum area, so it's just lifting up because of the high cone heights in this area. So what is OCT ophthalmology? We all know, very important for diagnosis, even deciding treatment, and of course follow-up. So all three areas of our managing patients is covered by the OCT. And of course, as already we have discussed, neuro-ophthalmology. We will be leaving out the anterior segment here. So common cause of abnormal repeated optical polyneuropathy is the hyperreflective. So whenever the light will find an obstruction, it will come back, and that is what the machine catches. So the hard exudates, calcification, they will reflect the light waves, blood, scar, and epiretinal membrane. We are all aware that how reflective the ERM becomes on OCT. And of course, hyperreflective, when there is a fluid, there is retinal edema, when the light is able to go through, because we will not get any signal from there. Same as ultrasound that we see. And of course, this is again, I will come later, this is a very important part, loss of tissue. We do make mistakes when interpret this finding in OCT. So this is all the type of, that you have a software available that you go through the patient's eye and get the different data. Coming to the area that we look for, normally vitreous is very clear, and of course in certain situations you will get echoes, not very important from our point of view, that much, more of say teaching the students. Vitreal interface is one of the most important thing, particularly in diabetics, that you have to look for. Foveal contour is another area, and intraretinal, of course, and subretinal fluid will have different implications. And we all know about that in diabetics, such an important thing to look for all this. So vitreous normally is clear, so you can have floaters in vitreous. Astrodialysis gives a very interesting picture on OCT. So they see like falling raindrops you will get. And there is a large vitreous floater which is producing a shadowing effect. Preretinal abnormalities are again very important, that we always have to look for and see whether there is any traction or any thickening of the ERM. So this particularly becomes very important in diabetic patients. Sometimes you might feel that you are not able to see that clearly in edema in diabetic, but vision is poor. When you do an OCT, you find very clear-cut VMT, and this of course a clear-cut indication for surgical intervention. We all aware, and you must have seen all these pictures over and over again, but it's very important from the patient's and the surgeon's point of view, that you clinically you see, okay, it looks all right, doesn't look that bad a macula, do OCT and you find this picture and gives you the whole idea of the poor vision. Epiretinal membrane, again, it's a surface on the retina, hyaloid and all that, makes thicken with the age. Again, this has to be taken with a pinch of salt. Don't run for surgery in any ERM that you see. Always correlate with the vision, the patients having symptoms or not that. So it can be focally adherent and globally adherent. Normally here you should not rush for surgery unless you are really documenting the vision is falling down. Focally adherent, of course, and if it is affecting the foveal area, of course you have to intervene. So this is, see, there is a change in the retinal texture, but again you have to correlate with the vision. Sometimes OCT like MRI shows more than actually what is needed to be done. These are the, I am just making the routine lineup for the diseases. Important areas will be this retinal edema. Again here this has come a handy for us. You operate a good cataract, you have no problem, but the patient suddenly complains after 2 weeks or 10 days that vision has gone down. You are worried and you do an OCT and you find edema, then you can reassure the patient. Most of these patients will improve on their own. You have to just wait. Subretinal fluid, again, you have to pick up in many situations, and it has one indication that these patients are going to recover better vision than intraretinal fluid. Macular hole, of course, it is a guiding principle nowadays. Again, this lamellar hole or pseudo hole. Sometimes on clinically it appears like a full thickness hole, but when you do an OCT, you find them. Then you have to again reassure the patient. And juxtafoveal telangiectasia. I will come to this. So this is of course, this is one, I will just find a clinical important thing I would like to mention about the BRVO, that if you see half of the retina thickened, you are only seeing an OCT picture, then you should can get that this could be a BRVO. And this is of course the diabetic edema again, but here again you see this. But normally if you say only half of it going up, the most possibly of a BRVO is very high. And CRVO of course is a edema is very high, very thick. Macular hole, of course, we are not going detail. Is a diagnosis and staging, associated ERM, surrounding retina, cystoid and prognosis. We have the whole foreign factor and all those things to go a long way in deciding the surgery and about the prognosis that you will expect to the patient. So again, this is a very common picture that you are all aware. So this is again an important thing when you go for a whole analysis. If there is a tissue left, even if a minor tissue left, these patients possibly will not need surgery immediately. You can just follow up. This I would like to highlight because we all have made mistakes. When you see these patients in the beginning, the injection you sometimes get carried away that could be an edema. But if you see the foveal contour is well maintained and there is evacuation, this is a loss of tissue. These patients are not going to improve any type of intervention. So just explain to the patient what is this situation like. Again, here I will not go in detail because we will be coming other talks. This neurosensitive attachment is a very important thing to look for in all your patients where there is some doubt about the why vision is not improving. Drusen, more of a clinical, say, academic importance, and really you don't actually make much out of it in OCT as such. And of course, we are not going into detail about this. We all have a lot of discussion on this ARMD, universal AMD, and the treatment is straightforward. But again, one thing that you have to always be very clear about, sometimes OCT will show a lot of changes and maybe some fluid and all that, but you must look for clinically the disciform you start. These patients are not going to do well with your injections. So don't rush through in these patients for interval injections. And this is again a dry type of macular degeneration. And these are some of the pictures, the pre and post treatment. Again, we have seen a lot of that. Again, one thing I like to mention here is CRV with myopic degenerations. If there is a distortion in the high myopic patients and there is a compromised vision, you may not find much fluid in these patients, but you should inject. These patients do quite well. They require much less in number of injections than other AMD patients. So don't wait for the fluid to come in myopic CNVM. And again, sometimes you have all made mistakes. The viral form is choppy and we have injected. See, there is no fluid around. There is no fluid around. And this is a thing which is now we are diagnosing more and more with the new gadgets that come, polyfocal vasculopathy. And of course, the one thing I just like to mention here, when you make a diagnosis of CSR, which is very commonly seen, just try to look, there is no intraretinal edema. If there is some fluid here, you should revise your diagnosis about CSR. So the important point is that in AMD, you achieve a full dryness, try to achieve. In diabetic, you should not go for that straight away. You can see the vision has stabilized, is not improving the injections, wait and just watch for the vision to drop, then you re-inject patients. When you have unexpected visual loss, you all come across unsatisfied patients, we don't know what has gone wrong. This is very important. Look for foveal atrophy. The thickness of fovea will go down, disruption of IS organization, and subtle serous detachment. The third one will definitely recover, but these two will never recover. So explain to the patient, try to tell them that this is what we can do maximum, can't do much about these patients. So thank you very much for your kind attention.